Hi, good evening, everyone. Just bear with me a few more minutes. Just going to wait for a few more people to join in, make sure no one's too late. So we'll start in a few minutes' time, okay? Okay, I think we've got enough people to start. So welcome, everyone. Good evening. Welcome to the third session for this mini series of webinars about anatomy and diagnostic imaging. So today's webinar is going to be on abdominal emergencies. Okay. So I'm Dr. Suleyman Ullah. I'm an FY2 in Basildon Hospital in the East of England Deanery. My colleagues Zaid, Tahmid, and Jawad have all done episodes before, and there will be 6 talks in total. So we're only halfway done at the moment. So we've got a few more really interesting talks to come still. So let's get started. So I won't go too much into these because it will kind of tell the answers to my questions. So the main learning objectives are going to be to kind of gain a better insight into how to interpret abdominal x-rays, so plain radiographs, but then also kind of an introduction into abdominal CT scans, learning to kind of appreciate the anatomy and then find out what's normal and then how to spot when something isn't normal. The key thing to remember here is that as a final year medical student or a junior doctor, you're never going to have any obligation to make any decisions based on a CT scan. So obviously, I would never advise you to kind of use this as a way to say, okay, this patient needs this. You should always wait for a report from a radiologist before actually making any decisions. But this will just kind of give you a better idea of what you're looking at. I think the issue from my experience and my peers is that the idea of getting a CT scan or even an X-ray is so that we can look at the images ourselves. And a lot of the time, people won't even look at the images at all. They'll just look at the report. And that is where the issue, I think, with current training is that we don't get enough of this training in medical school. We should have some sort of basic training into CT scans as well. And that's what our job is trying to do with this little mini series to get you ready to becoming FY1s, FY2s, whatever you're rotating into next. If you have any questions at any point, please just put it in the chat. There is a little bit of a delay on the streaming side. So just let us know if there's any questions. Some of my colleagues will be in the chat as well. They might be able to respond a bit quicker than me. But yeah, any questions for me, just say in the chat. So let's get into the first case. So 65-year-old gentleman presents to the A&E with 2-day history of abdominal pain, distension, and nausea and vomiting. He last opened his bowels 2 days ago, and he's got a past surgical history of bilateral hernia repair, which was 7 years ago. On examination, his abdomen is distended, and there's tenderness in the lower abdomen. So what would your suspicion be out of these options? What would you be worried about? And to be honest, with this presentation, it could be multiple options, I'm honest. So from just what would your initial kind of gut feeling be? And then we'll get into the imaging. Okay, I think this delay might be a bit worse than I'm expecting, or everybody's just really nervous to reply. So, oh, there we go. Someone said A or B. Okay, yeah, fair enough. I think that's a very reasonable answer. Let's get into it anyway. So we're not going to get a definitive diagnosis from this history anyway. We would always get imaging in this case. So let's have a look. So the CT scanner is down. So you've got an abdominal X-ray. Now, what does this show? So what we can see, I'll wait for you guys to answer as well. But what we can see these dilated loops of bowel. Um, I think we'll hopefully have someone comment on what type of bowel is dilated and how you can tell what type of bowel this is. Um, there's a clear distinction between a large bowel obstruction and a small bowel obstruction, which we'll get into on the next slide. So stacked coin appearances, consistent with small bowel obstruction, blocked colon. So that's two opposing answers there. We've got one for large bowel obstruction, one for small bowel. So this is a small bowel obstruction. So as Paruka Hannah has said, is that it's a stacked coin appearance. That I guess is one way of describing it, and it does look quite accurate. It does look like coins stacked on top of each other. Essentially, the way we can tell the difference between a large bowel obstruction and a small bowel obstruction is that from a kind of a basic way of describing it would be the lines go all the way through. So the bowel markings go all the way through. They're actually called valvulae conniventes. However, yeah, you can just say the lines go all the way through. So in contrast, for a large bowel obstruction, you would tend to see larger bowel. The actual width of the bowel would be larger because the large bowel can dilate more. However, the lines would not pass all the way through. They would only pass partially throughout the width of the bowel, and they're called haustra. So this is, in fact, a small bowel obstruction, as we can quite clearly see on our X-ray here. And this is something that you will definitely see during your foundation training. It's a very common presentation, not just in A&E. You will see this on the wards. I've seen it myself on a night shift. It's a very common thing that I'd be surprised if you don't see at some point in your career as a foundation doctor, or you might have even seen it as a medical student. So just to go through the clear risk factors for small bowel obstruction, I don't want to stay too long on this case. The main one and the kind of most common predisposition for small bowel obstruction is previous surgical history. So this patient, as we saw before, had a prior abdominal, they had a hernia surgeries, bilateral hernia surgeries. And these were laparoscopic, but even laparoscopic surgeries will leave you at higher risk of bowel obstruction. And that's due to the presence of adhesions, which is scar tissue that forms inside the abdomen, which can wrap around the bowel and cause kind of stricturing points, which would cause bowel obstruction. So even laparoscopic, even keyhole surgery procedures will cause this problem. But if a patient has had an open surgery, like a laparotomy, you will be at even higher risk. So these are the things that you need to make sure you get in your history. There are a lot of other causes for bowel obstruction. There's something called pseudo obstruction, which I won't go too much into, but that's due to things where there isn't a mechanical cause, where there isn't something blocking the bowel, but rather it's something like electrolyte abnormality. So commonly we see magnesium being low can cause a pseudo obstruction where the bowel wall doesn't contract properly, and as a result can give an obstruction like picture. And then also post-operatively, any sort of bowel surgery, bowel does not like being touched. So when it's touched, it will stop carrying out peristalsis, which means you can get a pseudo obstruction picture there as well. So as you can see, the telltale in this picture here on the right, you can see there's clips in the right upper quadrant. which would likely be from a previous cholecystectomy, so removal of the gallbladder. So that would also be a little clue that the patient's had previous surgery. This is just another slide on abdominal x-rays. I won't go too much. We've kind of explained all of this already. So as we said before, adhesions are the most common cause of small bowel obstruction, hernias as well. So we do commonly see hernias, particularly inguinal hernias, where bowel and particularly small bowel will get trapped in the neck of a hernia and won't be able to pass back. And that's called a irreducible hernia. And then if it becomes strangled at the neck, it's called a strangulated hernia, and that is a surgical emergency. So we commonly do see it there as well. Volvulus is another cause. Tumors, a very important cause that you have to rule out. And tumors you're not going to see very clearly on a X-ray. So the next step would be to get a CT scan. So we'll go through the findings of the CT scan next. Or not next. We'll quickly just go briefly through a management. The first thing that you can do as a junior doctor, always for something like this, you're going to escalate to your senior. If you're on the medical team, for example, you will, refer to the surgeons who will deal with this. The medical team wouldn't usually deal with small bowel obstruction. It would be the surgical team. You can treat this conservatively using a very strong laxative called gastrografin. That can deal with small bowel obstruction. And what that does is it's a drink that the patient will drink, and it has a very strong osmotic laxative effect. So it brings in lots of water into the bowel, and it can, in some cases, treat small bowel obstruction, particularly if it's an adhesional cause. However, a lot of patients do progress to surgery, and it does end up being a laparotomy, so a fully open midline incision down the abdomen, where you will, look carefully for an obstruction point, and the patient will go kind of removal of those adhesions if that's the cause, which is known as adhesiolysis. As a junior, what you can do and what is very important on your surgical rotations, definitely learn how to do this, because it will help you on a night shift where you cannot get the surgical reg to come and help you. You can tell the patient to become nil by mouth. If you give that patient more food and drink, they are just going to vomit it back up, and they will just worsen their small bowel obstruction. It's very important to insert an NG tube, which you should learn how to do. And that will decompress the stomach and decompress the proximal small bowel, and essentially alleviate those symptoms. Okay, this is a very important thing, and this is the one kind of takeaway that I would want you to take from this session, is knowing how to spot a small bowel obstruction. If a patient hasn't opened their bowels in a few days, the patient has been vomiting, isn't able to eat and drink without vomiting after, is in abdominal pain, you need to be concerned about a small bowel obstruction. So now we'll quickly go over the CT findings. So as you can see here on the left, we've got a normal CT. Apologies, I've not got a cursor or anything to show you, but there's some nice arrows here, so we can you can look at those. But as you can see here on the leftmost picture, we've got a normal CT. So you can see the small bowel is, again, it's hard to describe without a cursor, but you can see the small bowel, it's of normal caliber, normal width. Whereas in the obstruction picture, you can see these big circles with fluid, and then the black bit overlying, which is air. And these are pathologically large. These are pathologically wide, which suggests small bowel obstruction. And you can clearly see that in the rightmost picture, which is the coronal series, which are kind of the forward slices, I guess you could say. And you can still kind of see those lines going all the way through the bowel, showing that it's small bowel. And they are definitely wider than they should be. So what the radiologist would usually do is they would look through it, they would follow and track all of the bowel, look for the point of obstruction, and then that would be relayed to the surgical team, who could then look into that when they open the patient up for surgery. Okay. The next slide, I just want to quickly go over some anatomy of the abdomen. A lot of this, you already know. I won't need to kind of explain too much to you. Um, just an appreciation for the abdominal anatomy. This is something that you will all be very familiar with earlier on in your medical school careers, but it's something that kind of gets neglected a bit um, towards the end of your medical school, and then also as an F1, F2. There isn't actually a huge obligation unless you're on a surgical rotation to really kind of understand the anatomy. But um, as you can see here, you've got a axial slice on the left and then a coronal slice on the right. This is from a CT scan. Um, I won't go too much into it, but it just shows that I'm just trying to kind of show a labeled um, picture of the anatomy so you can kind of have a look at the scans uh, that are later on and have a better kind of understanding of what's going on. So the next case, I'm not even going to wait for you guys to answer for this. You should all be able to get this one. 22-year-old patient, sudden onset abdominal pain that begins near the umbilicus, a central abdominal pain, which then moves into the right lower quadrant. Pain associated with nausea, vomiting, low-grade fever. On examination, tenderness at McBurney's point, rebound tenderness. I couldn't have made it any more obvious. So, what is the diagnosis for this? So, I think someone has a question. Okay, that's a very good question. So the question is X-ray or CT the first line imaging modality when we have this patient in clinical practice? I will be completely honest with you. At my hospital, I can't comment on how this is at other hospitals, but at my hospital, you are never going to get in trouble if you have a patient presenting with that and you request a CT. At the end of the day, all the patients will, if they do have a small bowel obstruction, they will need a CT. Um, Good. I'm glad to see everybody is answering now. Good. So everybody's got it right so far. B, acute appendicitis. But back to that question, you can get an X-ray. An X-ray is a much quicker way sometimes of getting the scan. You can do it bedside. Sometimes they'll bring the X-ray machine and scan them. Um, However, whether it's first line or second line, the gold standard is a CT. That's what I'll say. First line, if you don't have access to a CT scanner in a quick fashion, um, an X-ray is a good option. But if you can get a CT scan in the next few hours, I would go for CT scan. Um, but again, it's all down to kind of what your trust guidelines are for this. So it kind of differs between hospitals. For me, I would request a CT personally. I've done it before where I go for an X-ray. Um, Sometimes X-rays will be ambiguous. If it's a really bad small bowel obstruction or it's perforated, you might not be able to actually see the bowel. So the gold standard is a CT. You won't get in trouble for requesting a CT if the radiologists say to you, why are you getting into CT and not an X-ray first? Then you can maybe get an X-ray, but I've never seen that in my experience. Okay, so well done, everyone. You've got this one right. That's acute appendicitis, a very classic presentation for acute appendicitis. Young patient with central abdominal pain that radiates to the right lower quadrant. Good. Okay. So tell me, this is the same patient. This was their abdominal X-ray. Can anyone tell me any findings on this abdominal X-ray? Is there anything that suggests any pathology in this X-ray? Okay, not as many answers this time round. So nobody's able to spot the problem on this X-ray. Okay. So you're all right. It's a trick question. There is nothing to spot on this X-ray. The only thing you would be concerned, well, we can go into that later actually, but you wouldn't usually see any findings on an abdominal X-ray for acute appendicitis, um, apart from in one scenario, which we'll go into later. Okay, but yeah, well done. I'll treat that as you all got the question right. There is no, the cecal region looks edematous, I think. Um, it'd be hard to spot that on an X-ray, I'll be honest. Edema um, on an abdominal X-ray. But I can see why you've said that though. Okay, so this I've not got an actual, a one picture of an appendicitis case. I've got three different ones where it's all combined and it shows everything clearly. So appendicitis, we see this in we used to traditionally see this in one age group, and that was a young, 15 to 25-year-old age group. However, now we see that there's two peaks of appendicitis. We have it at that 15 to 25 age group, and then also later on in life, we see it in older adults as well. Um, in the case of younger adults, it tends to be from the cause of an appendicecalith, which is essentially it's just a piece of hardened stool that gets stuck in the appendix, causing inflammation. However, in older adults, you have to be able to rule out um, cancer as a cause for triggering appendicitis. So um, I think in a lot of cases, there's guidelines for getting a patient should have a colonoscopy post appendicectomy if they're over a certain age to look for any kind of cancerous or precancerous changes of the bowel. Anyway, that's just a little bit of uh, kind of information about the presentation of these patients. It isn't just young adults. You do see this in older adults as well. So in terms of the findings, ultrasound is often used to diagnose appendicitis. CT scans are the gold standard again. So ultrasound is only really uh, useful in a certain kind of age group and demographic group of patients. So you would tend to use ultrasound with children and then women of pregnant, women who are of childbearing age, because you don't want to expose them to unnecessary amounts of radiation, which you'd get with CT scans. The only issue is that ultrasound is less sensitive to appendicitis, and also ultrasound is very limited depending on the kind of habitus of a person. So if they are a larger person, you're not going to be able to see. If there's lots of fat, you will not be able to see the appendix clearly. So CT scan is the gold standard. I think sensitivity is around 90 to 95%, whereas ultrasound is a bit lower. It's in the kind of 70s, I believe. I can't remember off the top of my head, but yeah, CT is definitely a lot higher, 90 to 95% sensitivity. So what you would see on both scans, you would see dilation of the appendix. So this leftmost picture, you've got the arrow that is pointing to the appendix. Yeah, so it's dilated at more than 6 millimeters. That looks like it's closing on a centimeter, maybe even larger than a centimeter, which is definitely pathological. And then you would also see fluid in the surrounding space. So you can see a lot of fluid, which will go down the right paracolic gutter. So if we go back to our anatomy picture, if you can see on the rightmost picture where it says cecum, instead of it being black around the cecum, um, you would see a more kind of hyperdense color, similar to kind of the color of where it says psoas around the cecum, which would suggest the presence of fluid. Okay. The next most important finding is an appendiciculus, which would look like on the rightmost picture, you would see a hyperdense object, a hyperdense lesion within the appendix. So you've got your cecum here on the rightmost picture. You've got your cecum, and then you can see this appendix, which is marked by the which is marked by the yellow arrow, um, the appendix is extending out of the cecum, and then where the arrow is focused on, you've got the hyperdense, so that is bright on CT. Hyperdense is bright. Hypodense would be more dark, and that suggests the presence of appendiceal. The middle picture is probably the hardest to spot and will take time for you to kind of appreciate, um, but it's something that you will spot as you get more experience with this. um, is something called periappendiceal inflammation. And what that looks like and what it's called by radiologists is fat stranding. So, as you can see on the other pictures, you have a nice kind of black area around the organs, around the muscles, vessels, and organs. Um, and what we could see here is you can see a haziness around the appendix, which is marked out by those arrows. That is called fat stranding. And fat stranding is a sign of inflammation around the affected organ. So, in this case, the appendix. There's inflammation around which is spreading to the fat and causing this stranding appearance. Um, that is another thing that's pathognomic for appendicitis, and is not exclusive to appendicitis as well. You will see this with all types of inflammation. You'll see this in inflammation of the kidneys, inflammation of the gallbladder, inflammation of the descending colon in diverticulitis. You will see this with many different conditions. So that's something to look out for as well, and something you become more experienced with as you get more experience with looking at these scans. Okay, next slide is, let's imagine it's the same patient. So it's this 22-year-old that we've diagnosed. We've got the CT, that we've diagnosed them with appendicitis. Initially, the patient just had uncomplicated appendicitis on their scan. Now, what worries you about this X-ray? Okay, and you might be thinking, why are we getting a chest X-ray for this patient? They've been diagnosed with appendicitis. Why are we getting a chest X-ray? What I want you to tell me is, well, let me give you a bit more background. So let's say this patient, they couldn't get on the list for today, so they're booked for tomorrow's list for surgery. But they suddenly started complaining of severely increased abdominal pain. What are you worried about after seeing this chest X-ray? Amazing, amazing. Well done. So we've had multiple people answer that already. So air under the diaphragm, otherwise known as pneumoperitoneum. Pneumo referring to air, peritoneum regarding to the abdominal cavity. So we can clearly see there's air under the diaphragm here. Sometimes it can be quite subtle to see because it almost looks like the lung, it follows the normal kind of contours of the lung. However, as you can see here, you've got a kind of white arch, which represents the diaphragm's dome, the right hemidiaphragm. In that case, you should not be able to see any black, which would refer to air underneath this. So this is an erect chest X-ray where the patient is standing up, and when you stand up, air will rise to the top of the abdominal cavity. So that's why we can see air quite clearly on the right side of the abdomen. So this is very, very concerning, as people have very rightly suggested, for perforation. So it's likely this patient, might have had an uncomplicated appendicitis initially, but the disease kind of progress has worsened, and it's resulted in a perforation, which is not an uncommon thing to see with appendicitis. The common complications of appendicitis are perforation, are abscess, and necrosis of the surrounding area. So this would suggest a perforation of the appendix. Would this change the management? No, it wouldn't. But it would warrant the patient to maybe have overnight surgery. Normally, you would wait for the next day if the list was full. this might warrant the patient to, call the consultant in to come and do the surgery more urgently. Okay. So again, the important factor here is that just because you have a diagnosis doesn't mean you should ignore a worsening of the presentation. So if the patient has come in with appendicitis, you've given them pain medications, and then they complain of a severe worsening of the pain, then you're within your right to get repeat imaging, to kind of check for any worsening of the patient's condition. Okay. Perforation is not limited to just appendicitis. You can get perforation in many different abdominal pathologies. Another important one to remember is diverticulitis. So I don't actually have a slide on diverticulitis because I was worried we'd run out of time. But diverticulitis is, inflammation of little pockets that form called diverticula in the large bowel. These little pockets that form with age can become filled with little parts of sediment that get infected and therefore cause this diverticulitis. These can also commonly become perforated and can result in patients needing emergency surgery. So it's very, very important to look for perforation, and to if you've diagnosed someone with appendicitis, if you diagnose someone with diverticulitis, make sure you read in the report at least, of the CT scan, that there is no evidence of perforation. That's a very important thing. If not, you're within your rights to call the radiologist and say, can you comment if there's any evidence of abscess, perforation, things like that. It's a very important thing to look for. Okay, so we're going to rattle through these next cases. So please tell me what you think of this abdominal X-ray. So toxic megacolon, it is a very dilated bowel. We can definitely see that. This is more kind of a classic. What is the Sorry, I'm not sure what you mean by anamnesis. Um, so good. Okay, Rain's got it. So sigmoid volvulus. This is the classic coffee bean sign of a sigmoid colon volvulus. So yeah, we don't need to go through the history. This is what would be a classic history of it. I won't go too much into it because we know the answer now already. But yeah, this is a sigmoid volvulus. Well done. And it's the classic coffee bean sign. Okay, so as you can see here, it's a twisting of the sigmoid colon on its mesentery, which can result in obstructive-like symptoms and also pain as well, and can result in kind of long-standing constipation. And it tends to be seen in patients actually that are on chronic laxatives. So they have chronic constipation and therefore have kind of almost overuse of laxatives. So we do commonly see this in older patients. And if they've been using laxatives for a very long time, there will be, more prone to volvulus. Also decreased mobility as well. So you'll commonly see this in a care home resident that's come in. They've got dementia or Parkinson's. They're on 3 different laxatives and they have been for 5-10 years. Another, subset of patients do see this in is, older patients with mental health conditions like schizophrenia, where they have a kind of predisposition to needing laxatives due to their medication, but then they also have poor dietary habits as well. Okay. So yeah, the management for this would be a rigid sigmoidoscopy, and you would insert a tube called a rectal tube where you'd be able to kind of decompress the sigmoid, because what you'll tend to get is fecal impaction, which is essentially the what's a nice way of putting this, is the buildup of stool in the sigmoid, um, and the inability for the patient to pass this because of the obstruction, because of the volvulus. So it will need almost what we call manual evacuation of the sigmoid colon. Next one, similar presentation. Tell me what you think of this X-ray. I'll be back in a second. Anybody gonna take a guess with this one? Well done, Rain. You got it again. So this is a cecal volvulus. So this is spotted by what we call the embryo sign or fetal sign, sometimes called, where you can almost kind of see the image of an embryo on here. So this is a cecal volvulus. It's a lot less common than a sigmoid volvulus, but cecal volvuluses can be a lot more concerning. So again, they should warrant kind of referral to the general surgery team. And it's again caused by similar presentation, similar kind of background. It's more due to kind of chronic constipation, and you'll tend to see it in care home residents, dementia, spinal cord injuries is another one, stroke, and it's more to do with kind of reduced peristalsis, which results in chronic constipation, and therefore a volvulus, a twisting of the mesentery. Another key one here is actually pregnancy as well, which is important to mention. You can see this in pregnancy due to the increased abdominal pressure, which you'll tend to see later on in the pregnancy. So this one is normally managed. It can be managed a lot more acutely because of the risk of it relapsing, even if you solve it once. The good thing about sigmoid volvulus, I wouldn't say good, but the better thing about sigmoid volvulus is that it's much more distal. You have a lot better access per rectally, essentially. You can go in quite easily and fix this. With the cecum, it's all the way at the proximal colon, so it's very hard to access unless you do so surgically. So a lot of the time it is surgical management to solve this, and sometimes does need kind of removal of part of the bowel. Okay, this is just a little question. I'll let you guys answer this one. So 68-year-old man, history of abdominal discomfort, nausea, progressive distension, not past any stool or gas. This one should be an easy one. Good, well done. So everyone's getting this one, small bowel obstruction. This is one we've discussed earlier. The recent surgery is a big telltale. Obviously, the CT scan, which shows fluid-filled, dilated small bowel loops. You've got the answer there. So yeah, good. Well done, everyone. Next, 75-year-old lady. Um, Again, I think this is one we've just done. So actually, I don't think we'll do this one because I'm not going to bore you with the same one we've just discussed. Yeah, it's a cecal volvulus. We've just done this. So as you can see again, we've got the kind of fetal sign, but this kind of shows how it's not always so obvious as the picture I showed before. But yeah, this appears like a cecal volvulus. I've not given much. This is a tough one because I've not given much history to kind of give it away. But yeah, this would need discussion with the surgical team, consideration, depending on the presentation, consideration of surgery. I guess the other thing that they mentioned on this one, and by they I mean us, is that there is potentially some evidence of early small bowel obstruction. You can see um, some increased diameter small bowel. I wouldn't say it's a full-on small bowel obstruction, but it could potentially progress to that. And the reason why, if we quickly go over our anatomy, is the cecum is in the right iliac fossa. The cecum is the first part of the large bowel. So if you have a twisting or a volvulus at that part, you are going to cause a small bowel obstruction as a result. Because if you can't pass anything through the cecum, food is going to back up into the small bowel and cause an obstruction like picture. So this kind of shows how you can have two issues going on at the same time. Next one, I'll be very impressed if someone gets this one. I definitely would not have got this one as a medical student, so I'd be really impressed. So this is a 32-year-old man. Pay particular note to the the age of the patient. So chronic diarrhea, abdominal cramping, intermittent weight loss, blood in the stool, low-grade fever over the last 3 weeks. He's got no medical history, and this is what his abdominal X-ray shows. It shows thickened bowel walls and narrowing of the lumen, particularly in the terminal ileum. So there's a lot of kind of classical features for one particular condition. However, this would have been a quite difficult finals question. Okay, so we've got some answers coming in. We've got UC again, we've got Crohn's, UC, Crohn's. Okay, so it's a mixture between UC and Crohn's. So essentially, you think this is an inflammatory bowel disease from what people are answering here. That's really good. The fact that you've even narrowed it down to inflammatory bowel disease is very good. Okay, so the key thing to note in this is the clinical history. It's really, really important. Although this is, particularly about anatomy and imaging, it's really important to get a comprehensive history. So the patient has chronic diarrhea, intermittent weight loss, blood in the stool, and a low-grade fever. So those four things, abdominal pain can be general. It's not gonna, abdominal pain or discomfort is not gonna differentiate between different conditions. But chronic diarrhea, intermittent weight loss. First of all, the intermittent weight loss tells you it's not IBS, irritable bowel syndrome, because irritable bowel syndrome can give you diarrhea, but it won't cause more severe symptoms like weight loss, blood in the stools, or a fever. So we can get rid of that. Infectious gastroenteritis, the fact that it's 3 weeks would kind of point me away from that diagnosis. Celiac disease, is a very important one as well, especially in an age group like this. Although normally it would present earlier, and you wouldn't tend to see these sort of findings on the imaging for celiac disease. Um, and then also, to my memory, I don't believe blood is as common in celiac as it is for inflammatory bowel disease. Fever is also um, a bit more rare to see in celiac. In celiac disease. So essentially, it's important to kind of get rid of your other differentials. Now we're left with UC and Crohn's. The way we can differentiate this is from one point. Okay, UC tends to only affect the colon. We've got particular findings suggested in the terminal ileum, so that would point away from UC. Um, Crohn's is a disease which affects all parts of the upper GI and lower GI tract, all the way from mouth all the way to rectum and anus. So, um, but one of the classical um, key areas it affects is the terminal ileum. And if here you can see thickened bowel walls and narrowing the lumen, the thickened bowel walls would be suggestive of pathology, definitely, and potentially chronic inflammation. So blood in the stools is another very key feature of inflammatory bowel disease. So you should always see that as a red flag in a young patient, a relatively young patient at 32. Okay, so we'll go into the kind of description then of the key findings. Again, this is a very difficult one. I would not expect anybody to, be able to diagnose Crohn's disease on an abdominal X-ray. Okay, that's really not going to be diagnostic of this condition at all. The gold standard diagnostic test for Crohn's is a biopsy, which is usually done via colonoscopy, or sometimes, through an OGD, so a scope from mouth, and a scope of the colon. So they call it a top and bottom scope. Also, you wouldn't even, the best modality of diagnosis for Crohn's and UC is an MRI of the small bowel. Sorry, just for Crohn's, not UC. So it will be an MRI of the small bowel, and you will see these skip lesions. You will see strictures, which you won't be able to see clearly on an X-ray. And maybe in a very severe case like this, you will, but on most patients, you won't be able to see this. So they would normally be referred to the gastroenterologist for further investigation with an MRI, small bowel, and a top and tail OGD and colonoscopy. And then we know about there's a lot of family history of Crohn's and inflammatory bowel disease, so it's important to get a extensive history of the parents and first degree relatives. Yeah, so very good. Well done, guys. Next one. So 48-year-old lady, intermittent bloody diarrhea, urgency, and crampy abdominal pain, worsening symptoms for the last week. She reports that her symptoms are now accompanied by fever, tachycardia, marked abdominal distension, and she has tenderness in the left lower quadrant, and she appears to be febrile. What do you think from this? Okay, so we've got a quick answer from Peruka. We've got D, which is toxic megacolon. What does everybody else think? We'll give some more time for people to answer. This is one they like to put in, med school questions. Okay, good. I think most people were agreeing on toxic megacolon. Well done. So, yes, this is a diagnosis of toxic megacolon. So, the issue I have with this diagnosis is that it's not a specific diagnosis. This isn't kind of, toxic megacolon isn't always caused by the same thing. So it can be caused by infective causes and inflammatory causes. So it's not specific. It's more of a radiological finding rather than an actual diagnosis itself. But what it suggests is just severe inflammation of the large bowel, causing severe distension and increased caliber of the bowel width. Um, it's at higher risk of things like perforation. So if we go to the next slide, it will have an explanation. Yeah. So it's, it says here it can be a severe complication of UC. That does tend to be the cause, but it can also be due to infective causes as well. So it's not exclusive to UC. But as you can see here, we have a loss of the Hausstraw markings, which are the folds and lines that we see across large bowel. So when you see, an increased caliber of large bowel and then loss of the markings and the loss of the Hausstraw markings, you need to be worried about toxic megacolon because they are at a very high risk of perforation. Um, and they usually will need to have some sort of intervention. Otherwise, it will be an impending perforation, which can lead to peritonitis and then, subsequent death if not untreated. So it's something to be very wary of. Okay. So next, we'll go to the bonus question. This is a pediatric question. Got a 2-year-old boy, intermittent abdominal pain, vomiting. Um, he's got current jelly stools. Okay, this is a very classic, pass med question. Current jelly stools. A sausage-shaped mass is palpated in the right upper quadrant. And then this is an ultrasound that the patient's had. Okay, this is an ultrasound of the abdomen that we've taken for the patient. What is the diagnosis? Okay, I'll wait for some more answers to come in. Okay, I think everyone's agreed. Well done. This is intussusception. So the characteristic target sign on ultrasound, which we can clearly see on the right picture, the right-sided ultrasound picture. The left side, I think, is a longitudinal view of that same bowel, but it's very clearly seen as that target sign on the right-sided picture. So what the target sign is made up of is bowel within bowel. It's what we call telescoping of bowel. So if you imagine a telescope, when you collapse it and put it together, it all kind of collapses into itself. That is essentially what intussusception is. And we do see it in young patients around 2 years old. But it can actually be seen in older patients. I have actually seen it once in older patients, and it causes small bowel obstruction. So, and you can see it very clearly with this sign as well. So, it's not exclusive to pediatric patients, but it's a key one to look out for if you have a pediatric rotation. But yeah, it's bowel telescoping within each other, which will give that characteristic picture of a target sign. That's a key thing to remember. Do we have any explanation, or is it just... Yeah, okay, good. Yeah, so sausage-shaped mass is due to the kind of, it's the accumulation of multiple segments of bowel within each other, which gives it almost like a mass feeling. But it's a common cause of obstruction in children, and it requires management. Normally, it's with an air enema where they'll pass a tube up the rectum, and they will basically push air through that tube, and it will cause a kind of unfolding of the telescoped bowel. Yeah. So I mean, that brings us to the end of the presentation. Please do ask any questions. I know I was moving quite quickly through those slides, but we do have a lot of time left, so please do ask as many questions as you want. Just please add any questions to the chat. Otherwise, I would be really, really appreciative if you could scan the QR code and leave some feedback. Positive or negative feedback. We just want to know how we can improve our future sessions, and what you guys liked about this, what you guys maybe didn't like so much about it, so that we can improve it in the future. Again, this is our third session out of 6. So if you've missed the 2 previous ones, they are available on the YouTube, Mind the Bleep YouTube. So please do, rewatch those if you're interested. The feedback link, if you're struggling with the, I'll just say feedback link is also in the description. So it's also in the description if you're unable to find it there as well. But yeah, we'd really appreciate any feedback. And then also just a quick little thing. We are also running a conference, which will be this weekend on Sunday at Imperial College London. It's a hybrid conference, so you can attend online and in person. Can I move this? Let me see if I can move this out of the way. Jawad, if you can send the link for the conference into the chat, or I can maybe do it as well. But yeah, this is a conference we're running this weekend on Sunday. So this is being run by actually all 4 of us that have been doing the sessions, and then many other members. But yeah, please sign up. There's going to be, if you can't attend in person, it's going to be online as well. So you can watch all the talks online. In person, there will be a lot of chances to kind of meet radiologists who are at the kind of peak of their specialties or their subspecialties. You can gain some advice if it's a career you're interested in. There's also going to be lots of different workshops, including how to do biopsies. There's going to be workshops on how to kind of carry out endovascular procedures through simulation training. How to do, ultrasound scans, how to do fast scans. There's going to be a lot of stuff going on. So please do, if it's something you're interested in, please do register. And I'll see you there on Sunday. Otherwise, if there's no other questions, we can wrap up now. And I will wait here for about 5 minutes or so, just to see if anybody has any questions. Yeah, feel free to ask for any, advice or any questions about any of the cases we went through. But yeah, thank you very much for attending, guys. We hope to see you at our next session, which I believe is next Tuesday. So please do attend if you're available. I believe it's going to be a session on cardiac. I believe it's cardiac pathology. So it should be very interesting. That's going to be done by my colleague, Dr. Zaid Nufal. So yeah, please, please do come back next week and we'll see you there. But yeah, if there's no other questions, I think we will wrap up here. Thank you very much, guys. And